Ladies and gentlemen, we're very thankful to Professor Vijayalakshmi, our chairperson. She has been kind enough to present one case that will follow with a 2-minute discussion. Professor Vijayalakshmi, please, for the next 8 minutes.
Good morning, everybody. All along, all of you know the use of streptokinase for the acute myocardial infarction. And here I'll show a rare case where we use streptokinase for bailing out the child. This was a 5-year-old child presented with a history of high degree of fever for past 20 days, history of wound over the right foot since 20 days, febrile tachycardia, tachypnea. The child was so sick and he had muffled heart sounds, no murmur, right leg cellulitis was present, and we took the culture from that. And this is what the echo and the emergency echo done in the ICU was seen. Can anyone tell what could be the diagnosis? I think Dr. Indrani is there. There appears to be some mass in the pericardium, but if you take the history of fever for 20 days and cellulitis, we thought it is a pyopericardium. We put the needle and then aspirated the fluid and gave 10,000 units of streptokinase into the pericardium. And the whole of the mass that was there seen on the first day, it disappeared and the whole mass got pulverized, and this is how you got the swinging heart with all looking like a turbid fluid. Usually pericardial effusion, you have either clear fluid or you have fibrous bands, but this was something very unique. So this is the result of 10,000 units of streptokinase, and that is a real swinging heart with the collapse of the RA and the RV. You can see that literally RA, RV collapse, and that's how we got the swinging heart. And we aspirated 2060 ml of clear pus from that, and again second dose of streptokinase was given, and this was still there. The pigtail was kept inside the pericardium, and then every day we were doing the lavage with the vancomycin and then giving the streptokinase after that. And ultimately, after 3.5 lakhs of streptokinase and antibiotic with the culture sensitivity and the daily lavage with the vancomycin, this is the end result that we got. So initially the streptokinase was used for the pleural fluid to prevent the thickening of the pleura, but now people have forgotten the use of streptokinase for the pyopericardium or the tuberculous pericardium. So here is an excellent case report where you don't have to send the patient to the surgery either for the constrictive pericarditis or for the effusive pericarditis. You can literally clear the whole pericardium with the proper antibiotic, vancomycin lavage and streptokinase intrapericardially given. And so intrapericardial streptokinase for the fibrinous bands in the purulent pericarditis was reported as early as in 1954. That means when I was only 4 years old. But many cases have been reported, small series are there, but most of the cardiologists are not using streptokinase for the pericardial fluid. So streptokinase formerly was so the key message here is consensus till date to recommend the surgical subxiphoid pericardectomy, and you can see that none of our past 12 cases of pericarditis have gone for the surgery, and all of them we have managed with the intrapericardial streptokinase. So this is another case, 9-year-old child who came with the breathlessness acute within 1 week, and again the child was sick looking, and you can see that the X-ray shows there is a pleural effusion and there was a moderate pericardial effusion. It was only 10, 8 or 5. So unlike the previous case here, the pericardial effusion was not much, but you can literally see that the RA collapse and the RVOT collapse was there. So the video is not playing. And this amount of RA collapse with the moderate pericardial effusion is something very unusual. And whenever you have a case like this, acute history, and then you have tamponade, swinging heart, you must think of the malignancy. And in this patient, the total count was 90,000, and the patient had tamponade because of the acute accumulation of the fluid. So in tuberculosis, to get the tamponade, it takes long, whereas in case of malignancy, it is very acute, and as a result, there is no time for the pericardium to stretch, so you get the RA-RVOT collapse very easily. And this swinging heart indicates that the patient had thing. So what the mind does not know, eyes will not see, and what the eyes will not mind, one cannot interpret. So here I would like to say that streptokinase still, it's a useful armament in our thing, and acute pericardial effusion tamponade should not be missed, and that patient happened to have leukemia, and then the patient went for the chemotherapy. Thank you very much.
Thank you for such amazing cases, and thank you for that very philosophical ending. So if I can just request you, if you could share, you have so much experience in this, can you share with us and with the audience what our take-home message should be next time we see a febrile young child like that? When do we know when to intervene as you have done?
So whenever we have a IVC dilatation non-collapsing, then there is a spontaneous echo contrast in the IVC. Think of the pericardial effusion, constrictive pericarditis or pyopericarditis. Whatever mass we see need not be a malignancy. It could be the hardened pus itself if the patient has come very late. So that can be dissolved with the streptokinase. For the children, we give 10,000 units initially and see the response, and every day go on adding another 10,000 units into the pericardium. And this treatment clearly avoids the surgical intervention, and the surgery, whether it is a pericardectomy or just a thoracotomy, they have their own problem, and then again the secondary infection. Whereas when we put a sheath and then a pigtail and do the lavage every day and give streptokinase, we get an excellent result without a scar, a small nick in the xipisternum. That's all.
Very nice. Thank you. Any questions from the audience?
Madam, may I know that what was the organism in first case?
It was a MRSA.
MRSA.
Yeah.
Madam Chairman, we do not have any other speakers, so we'd like to thank you for chairing the proceedings. Thank you very much.